let's say they have gallbladder disease.
Yes.
Tell us the modern way that you're going to manage this gallbladder disease. Because that's a common way to come to an emergency room.
Very much so. It's one of the most common problems that people have. Over 20% of the population have some issue with gallstones or gallbladder disease. And if you could bring up a picture, I can kind of give you an idea where the gallbladder is located. Most people will notice this little green oval structure is up under the liver, and it's on your right side, up under your ribs. In that green structure called the gallbladder is where you develop gallstones, or you can have just dysfunction where it doesn't empty. The job of the gallbladder is to empty bile, that bitter stuff when you have the vomit. Its job is to help digest our wonderful North Carolina Southern food. And when it's not functioning well, you notice after you go to a restaurant and eat something, you get that pain. So you get an ultrasound, usually is the first study to get performed in the ED to look for gallstones. And if they find gallstones, then we can admit you to the hospital if it's an acute attack that requires surgery right then. If your pain gets better, then we can let you go home and you decide to do the surgery electively.
Which means as a scheduled thing, as
an outpatient surgery, on a day you choose. We have a video of a gallbladder surgery being performed robotically.
But before you show that video, my first incision that I ever made on a human body was for a gallbladder.
Yeah.
And it was an accountant, and I felt so guilty about the length of my incision. I used them. He was a horrible accountant. I used them for 15 years, and I felt so bad because this incision was this big.
Oh, wow. That was an open gallbladder.
Oh, it was an open gallbladder.
Yes.
Because you had to be able to get your hands in there.
Yeah.
You had to see it.
Yeah.
You had to be able
get
to
your
grab.
hands in, feel it, see it, yes.
Right. And then, after you made this large incision, then you put a tube inside.
Yes.
It drained out. You stayed admitted to the hospital for 5 days at least.
Wow. And your recovery was a couple of weeks, whereas laparoscopic, usually within a week, you're back to doing your normal thing. You're home usually the next day. If you schedule it as an outpatient surgery, you're home that day after surgery, that same day, and you're home and you're eating and you're starting to move around and get up and walk, and within a week, usually you're back to eating your regular food.
Wow.
Yeah.
I just remember when I was doing rounds as an intern, people throwing up for 5 days in the hospital.
Exactly.
And not eating normally for several weeks.
Yes.
Yeah.
Yes.
What a change.
So you're going to show us a robotic version of doing it?
Yes. And the reason why a lot of doctors do it robotically versus the laparoscopic is, one, the magnification, and two, is this wonderful system called Firefly that can turn your gallbladder green so we can see the anatomy a little bit better. We give a little dye before surgery.
It's a digital enhancement?
Yes, so it's a medication that's in your bloodstream that the camera reflects off of, and it turns it green.
Well,
it's pretty cool.
So it looks just like the diagram.
Yes. It's pretty cool. You can pull up the video and I'll kind of talk you through. So the gallbladder, it looks yellow there. That's fatty tissue that we're dissecting off. And I'm looking for the tube that connects the gallbladder to the intestines. And that's when it turns green with that Firefly. And so I can see the anatomy a little bit better. And usually the surgery is about an hour long, an hour and a half. And afterwards you go to recovery. You get excellent care and recovery and pain management, and then you'll be discharged home. The great thing about getting it also done robotically is the minimal need for pain medication. With the national crisis with narcotic abuse, we want to minimize people exposure to narcotics, and that's one of our ways of doing that.
Oh, sure. The smaller the incisions, the better, the faster the recovery.
Yes.
I, for one, have rarely, if ever, refill a narcotic prescription, and I give half as many as I used to when before my endoscopic surgeries came out.
Right.
I do all my, for example, carpal tunnels through very small incisions.
Yeah.
In the hand, it's called endoscopic. In the belly, it's called laparoscopic.
Yes.
But it's the same thinking. And I've been doing endoscopic surgeries for 20 years, and I've never re-prescribed or refill for a narcotic.
Yeah.
You know, so and now that our procedural dictums from the state have told us that we can't give
Yes.
extra narcotics.
Exactly.
You don't have much of a choice as a
No.
patient because you're not going to get it.
Yes.
And so the smaller the incision, the more skill set that the surgeon has.
Yes.
So that you have a smaller incision and an outpatient surgery, the less likely you'll need it in the first place. And that's a
Exactly.
wonderful thing.
Yes.
I want to ask a question about the robotic because you're talking about the magnification. So for people who've never seen robotic surgery,
Yes.
you're looking at a screen, right, and
Yeah.
performing it with there, and those little things we saw on the screen a minute ago are your hands taking the place of your hands.
Exactly.
Little bitty things, but you are actually not even, aren't looking in there obviously with the little incisions. Tell us what you're looking at and the size of it and how that helps you.
So what I'm looking at, I'm actually sitting at a console that almost has those little cameras like those 3D gaming consoles that you put on your eyes. You sit up there and you can see what the camera is showing me inside of your abdomen. My assistants in the room, they have a big TV screen. So when you think about the magnification, think about the original flat screen TV, how it was wonderful compared to the tube TV, and now the 4UK TV, how you can see the pores of an actor. That's how great the magnification difference is now, that I can see such tiny detail looking at this into these goggles. And then I have hand controls that are controlling everything that the instruments do. So I'm still in the room, I'm still involved, I put all the instruments in, and
Plus
then
the
I control
camera.
it. Yes.
And where is the camera located?
It's located, usually the incision is in your belly button, and it's a long cylinder-like tube that we slide in the camera, and it's in the belly. And it attaches to an actual machine, the robot, that holds it still. So it's not dependent on somebody, whether they have a shaky hand or if they're distracted by something, the camera goes in the wrong direction. I control all of the instruments.
So
Yeah.
an image, for people who can't envision what this looks like,
Yes.
it's kind of like one of the Transformer movies.
Yeah.
Where a machine, it's a white machine with multiple arms, like a spider.
4 arms, yes.
4 arms.
Yes.
And those 4 arms are controlling instruments and a camera.
Yes.
That's inside your belly, but you're not standing over like the person like
Right.
we're used to. You're all to the side of the room,
Right.
sitting down at a console like you're playing a video game.
Correct.
Really, but you're doing detailed surgery and you're looking into a monitor, seeing much greater detail than if you were actually standing over the patient.
Right. Greater detail than if I had my hand in the patient.
Right.
Yeah.
And working machinery that has the ability to manipulate much more precisely than your hands could.
Yes, and they can get in the small, tight places and have 360 movement that helps do the dissection and
the risk, the damage to tissues that are right next to them is way smaller.
yes.
An infection, you're not opening up big wounds for infection or
Exactly.
anything too.
Yes.